So today I wanted to discuss how we approach the evaluation and treatment decisions in a child who's presented with a first unprovoked seizure. So essentially on the horizon of new-onset epilepsy. And again, I appreciate the introduction. I am from Los Angeles County plus University of Southern California Medical Center, the Keck School of Medicine, and I'm a pediatric neurologist. So our objectives, I'd like to go over what is epilepsy and how we go about classifying the hundreds of different epilepsies that exist, understanding the difference between seizures and other things that might happen suddenly and paroxysmally in children. I'd like parents and others to have an understanding of what diagnostic tests we typically consider in a child who's had a first unprovoked seizure, how that informs our treatment decisions. And I think as parents and as others involved in the care of individuals with epilepsy, how can we be better prepared for what's ahead? And also understand that seizures are not just a sign of possible epilepsy, but potentially could have impact on the person's mood, intelligence, learning, and future independence sometimes. So I always tell parents that the brain works like a computer. It's composed of billions of neurons that work electronically, much like a computer network. And we think of a seizure as excessive, uncontrolled electrical activity. And epilepsy is considered a neurological disorder that's characterized by unprovoked seizures. So a seizure can look like anything, but by definition, it's very, very stereotyped in the same individual with epilepsy, meaning from one episode to another, it almost always starts the same way. Now, it's true, it can evolve and some of the signs can change as that seizure goes on for seconds and sometimes minutes, but it should really start the same way. And it's characterized very often by a change in awareness of that individual. The most common seizure type in children and adults is focal seizure with loss of awareness, or what we call unaware seizures. And a lot of times there might not even be any significant motor manifestations, but sometimes it does evolve into stiffening, jerking, or kind of involuntary, bizarre motor behaviors. Now, that's a focal seizure. A generalized seizure is when most of the brain is consumed by this abnormal electrical activity at the onset of the seizure. And there isn't just confusion or loss of awareness, but there's complete loss of consciousness. So that's the difference between focal onset seizures that might remain in a specific region of the brain or spread to distant parts of the brain, and primarily generalized seizures, where at the onset, there's immediate complete loss of consciousness and awareness. And that distinction is important because it informs the potential cause of the epilepsy or seizure and also how we might approach its treatment. So I want the audience to appreciate epilepsy is extremely common. It's the fourth most common neurological disorder in the United States. But in children, it's actually one of the most common chronic neurologic disorders after migraine. So about 1 in 26 individuals in the United States at some point will develop epilepsy. So we diagnose many, many individuals in the US on an annual basis. And about a quarter to a third of individuals who develop epilepsy are more affected, and that's because unfortunately we are unable to stop their medications or control them completely with medications alone. Now, not every child who has a first unprovoked seizure goes on to develop epilepsy. And we understand that seizures inherently are frightening, unpredictable, and they're sudden events. So there were guidelines that came out many years ago actually literally 20 years ago that we still follow today, of course, with some evolution in our understanding of epilepsy and its treatment. So I'm going to go over these guidelines from the American Academy of Neurology and Child Neurology Society in terms of how do we approach the assessment, diagnosis, and treatment of epilepsy. So it's important to stress that an unprovoked seizure means that the seizure is not triggered by immediate head trauma, like from a concussion or some sort of brewing inflammation or infection in the child's brain, or from some sort of toxin or poisoning. So we obviously the seizures are coming from the brain, but there is no immediate provoking cause. And that's really critical as physicians for us to rule out, because there could be potentially life-threatening things such as meningitis or other types of infections that can present with a seizure. Now, a first seizure actually includes multiple seizures in a day, as long as the child is regaining consciousness in between those episodes. But it does not include seizures caused by fever spikes, which affect almost 5% of children, as young as 3-4 months of age, all the way to 6-7 years of age. And it specifically, unprovoked seizures excludes babies up to 1 month of age. And that's because anytime a baby that young has a seizure, until proven otherwise, we have to assume there's a very dangerous infection or something else going on in the brain, and we have to admit that baby and do an extensive workup. However, a first unprovoked seizure can include any type of seizure. It could be, again, focal onset, where the abnormal electrical activity is in one region of the brain. Now, it might spread enough to cause confusion and loss of awareness, and it could even spread to the entire brain and cause consciousness. The computer of the brain shuts down, or it could just remain in that one area. It also includes seizures where, as I mentioned, they're generalized at the onset. And so this includes convulsive shaking seizures, stiffening seizures, seizures that might not have any motor manifestations. But there's some seizures where we know as a neurologist, a child, by the time a family recognizes a certain seizure type, such as absence or myoclonic, which are little erratic jerks, or what are called drop seizures, probably that child has had tens, if not hundreds of those seizures, and it's always an epilepsy syndrome. We used to wait for that individual, irrespective of age, to have 2 or more unprovoked seizures separated by more than a day before we would say you have evidence of epilepsy. But then our guidelines were changed a few years ago, such that even with a single unprovoked seizure, now I want to stress, there are seizures called reflex seizures, where the trigger for the seizure is something that should not cause a seizure in a non-epileptic brain. So it could be certain lights at a certain frequency. It could even be certain sounds. So those are called reflex epilepsies, and many of those are genetic in entity. But even after a single unprovoked or reflex seizure, once we do a diagnostic evaluation that I'll go over, or even sometimes a simple history and physical, and if we determine that there is a higher probability, more than 60% chance, that that child's going to have a second seizure sometime over the next several years, we can already proactively diagnose epilepsy and intervene. And sometimes we see a child or adult and we already know exactly what epilepsy syndrome that they have. So we'll talk about that. And a person's epilepsy is thought to be resolved if he or she remains seizure-free for an entire 10 years and off of medications for at least 5 years. So we do have a relatively high bar where we say the epilepsy has resolved. Now, that doesn't mean we wait all those years before we consider taking medications off if a person is seizure-free. So again, as an epileptologist, when I'm seeing a child who's had a paroxysmal spell and I think it's a seizure, I'm trying, based on my history and examination, to determine, was it a focal seizure, was it generalized, or I simply don't know. And at the same time, I'm trying to figure out if they actually have epilepsy and if there's a specific epilepsy syndrome. Epilepsy syndrome is a more specific type of epilepsy classification that tells me what is the underlying cause. Structural means that there's something on imaging of the child's brain that is abnormal and has a predisposition to have this abnormal electrical activity or epilepsy. So it could be an area of old brain injury, whether it was acquired in utero or after birth. It could be a malformed area of the brain. It could be low-grade tumor. It could be many such things that we know are not normal and have a predisposition for abnormal electrical activity. Our ability to diagnose genetic forms of epilepsies has also greatly improved over the years, thanks to access to more refined and cheaper epilepsy genetic panels. Sometimes we see certain types of epilepsy develop after infections have injured the brain, or sometimes it's even part of a ongoing infectious process. And then there are other more rare causes of epilepsy where the immune system is attacking the child's brain and causing usually seizures plus other changes in terms of mood and behavior and movement, and other rare genetic or metabolic causes. So it's really important that we have to make the diagnosis that an actual seizure occurred at first. So the history is critical. And this is why when you see a physician, we're asking you very, very detailed questions. And it's always best to get the history from the eyewitness and whoever witnessed the child's spell. For example, so if it happened at school, I know it seems like a distant thought that our kids were attending school before the pandemic, but if it happened at school, we really want to get on the phone and try to get in touch with the witness, school nurse, because especially in childhood, there's so many paroxysmal events that come on suddenly that actually might even end up in a seizure, but they're not considered unprovoked. So for example, kids can have breath holding spells. These are usually kids under 3-4 years of age where there's some sort of emotional trigger or even a painful trigger, you know, where they bang their head or something and they hold their breath. And they hold their breath as they're crying. They can turn pale, they can turn blue. And because of the lack of oxygen to the brain, they can actually have a full-blown seizure or a loss of awareness and consciousness. Also, other people who are older might faint. And when you faint, and if you're not getting enough oxygen and blood flow to your brain, that could also cause abnormal movements and posturing and an actual seizure. But again, all of those are provoked and they are not considered causes of recurrent epilepsy. And then there's a number of individuals who have abnormal movements, such as tics, or they have cerebral palsy, and every time they get nervous or excited, they might have some stiffening, which could be confusing with seizures. All of us, when we're sleeping, we might have a little jerk here and there, and especially in newborn babies, they tend to have more of this. This is called benign sleep myoclonus, and it's not epileptic. Children, and especially infants, when they have acid reflux, it could be very painful, and they can have arching and posturing of their back, which could be mistaken for seizures. And again, panic attacks that cause hyperventilation, certain types of migraines, night phenomenon like night terrors, all of these things could be concerning for seizures. There's even children who have what's called self-gratification syndrome, where they realize, hey, if I rub my private area in a certain way, or if I'm on the high chair, it feels funny. So this is not really like sexual masturbation, but the movements that the child does and the changes in skin color are sometimes mistaken for seizures. There are many websites that have videos of these non-epileptic events that are very good teaching tools. Again, when we're taking the history of the seizure, many seizures that start in one area of the brain, especially if there's been more than one spell, the child or the care provider might notice a pattern where the person who's having the seizure always seems to be aware, because it starts with, let's say, their a left arm getting stiff, or they could have a subjective sensation out of nowhere, an intense sense of fear, or if they feel very nauseous, like they're going to throw up. So these are called auras, and they're very stereotyped, meaning they're the same exact sensation, feeling, before there's any confusion. And that tells us the seizures are starting from that region of the brain that controls that sensation. And they could spread and the child could lose awareness, but it's very helpful information for us as epileptologists and neurologists. Now, as the seizure manifests and continues, there could be changes in mood, behavior, vocalizations, motor movements that the person cannot control, sometimes only affecting the eyes, causing gaze deviation, or sometimes the entire head, breathing difficulties. And then what's really important is a lot of times when the child seems confused and is where the seizure is only manifesting as kind of an arrest in behavior, like a staring episode, it's really important as a care provider to try to provide some tactile nudging, some stimulation, not just calling the child's name. The reason that's important is most non-seizure staring spells that are behavioral, like daydreaming or attention issues, the child will respond immediately when you touch them and nudge them. But with epileptic staring spells, many times the child doesn't come out of it and they remain confused or completely unaware of what's going on beyond them. And that simple intervention from a care provider can help differentiate from a epileptic to or versus behavioral staring spell. Now, a lot of seizures, there's a post-seizure period called the post-ictal period, where after the abnormal excessive electrical activity, the brain cells are exhausted. And not surprisingly, that exhaustion is also mirrored in the child, who's very tired, remains fatigued. Sometimes there's a full a period of sleepiness. There could be headaches. There could even be nausea and vomiting after the seizure. And that history is also really helpful for us to differentiate epileptic versus non-epileptic events. So again, we know as physicians, and some common sense things that parents also notice, which can help separate recurrent spells that are more likely to be epileptic from those that are not. I mentioned many of them, including a true period of unresponsiveness to even touch, or very confused response, which usually falls into the epileptic category. Inability to speak, or nonsensical speak, or mumbling or groaning tends to be more epileptic, as opposed to yelling, stuttering, or uttering vulgarities. Also a period followed with confusion, drowsiness, sometimes agitation, headache, vomiting, is very often follows epileptic phenomena. Now, cell phone videos are something that's really revolutionized our ability to assess these types of episodes. They're extremely helpful to your doctor. So again, capturing your loved one's spells on cell phone video, obviously with their permission, is extremely helpful for neurologists to help differentiate seizure phenomenon from all the other things that can look like a seizure. Now, when we see that individual in clinic or in urgent care, and they've come in and we're getting a history and it sounds concerning for a seizure, what we're trying to determine again is there something really dangerous that is going on now in the brain, where I need to figure out right now, could this be a dangerous bleeding into the brain, some sort of a stroke, or a very serious brain infection, or some sort of poisoning, or any other distant factors that might have predisposed this child's brain today to have their first seizure. So things like a child who had a difficult birth, a child who had had to stay in the neonatal intensive care unit, who was born very premature, who already had abnormal ultrasounds of his or her brain, or even a child who's had significant developmental delay or disability, such as autism, intellectual disability, or cerebral palsy, where we know as physicians there is something genetic or acquired that has affected that child's abilities and brain function. And another manifestation of that same distant cause of brain dysfunction might now be epilepsy. Now, any child who's had brain surgery, who's had significant head trauma, usually leading to loss of consciousness, skull fractures, emergency department visits, we're worried about. Any child who's had multiple or very prolonged seizures caused by fever growing up, these are other risk factors for epilepsy. And of course, if that individual has a family history of epilepsy, then we are more concerned for genetic causes of epilepsy that can be passed down from generation to generation. So in terms of the tests that we do, once we've got an adequate history and examination, we've made sure that the child's airway, breathing, circulation is okay. If we're in an emergency department setting, and we've gotten an adequate history, we want to do a basic examination again, looking for any signs of persistent confusion, new neurological problems, deficits such as weakness, sensory loss, severe imbalance that just aren't going away. Now remember, it's normal after a seizure for about an hour, 2 hours for the child to be out of it, not back to his or her baseline. But if that dysfunction persists, we start to worry more and more as a parent or as a physician that something active might be going on in the brain that deserves immediate attention. But we're also doing this history and examination, again, to formulate a hypothesis, our best guess as to if this was what appears to be an unprovoked seizure with no immediate or dangerous cause, do I know what could have predisposed this child to this seizure today? He had a difficult birth many years ago. We know the brain suffered injury either in utero or sometime later. We know the child has cerebral palsy, and they've already had imaging that shows some area of brain injury, or they have something on their neurological or physical examination that tells us they're at risk for epilepsy. Or sometimes there's a significant family history of other siblings, first cousins, parents who have epilepsy, where we have a strong hunch this could be genetic. But a lot of times we simply don't know what is the cause of that child's first seizure and or epilepsy. So these are just some more things on the physical exam that the physician's going to look for signs of any trauma, problems with the increased pressures in the skull that might be from, extremely rarely in childhood, from cancer or tumors or bleeding or an ongoing infectious process spreading to the covering of the brain called meningitis. The skin examination is very important for a child who's had a new-onset seizures, because there are certain types of birthmarks or other skin markings that come on after birth, such as these pale marks called hypomelanotic macules, or these what are called cafe au lait dark spots and freckling in the armpit area, and also certain growths that come on later in childhood that might look like zits or acne, but in fact they're not. And these are markings that tell us this child might have a genetic, what's called a neurocutaneous disorder. Neurocutaneous disorders by definition affect the brain and the skin. So ends up in utero when we're developing in the mother's womb, your skin cells and your brain cells evolve from the same lineage called ectoderm. So sometimes skin findings actually tell us that there might be a genetic problem also affecting the brain and other parts of the nervous system, or even other organs. And of course, we're also doing a careful neurologic examination just to make sure that the child has normal strength and coordination, Because sometimes a first seizure leads to a subtle type of findings, such as subtle or mild cerebral palsy, where in fact that child has had lifelong subtle motor difficulties, which has never been appreciated maybe by a physician before. We don't have to order a single blood test or urine test if the child looks well and is back to his or her baseline, okay? The reason as physicians we order labs is if the child's still not well, or especially if it's in the emergency room, it's early, we want to make sure that child's blood sugar level is normal, it's not too low, or if they're not waking up or perking up immediately, maybe we're worried that there's something wrong with their electrolyte balance. If a parent is concerned that maybe the child took something either accidentally or there might be some illicit drugs involved, we might have to do testing of that kind. But if the child looks well and is back to their normal self, especially if it's been hours, if not days after that first seizure, we don't need to do any blood tests because they're not helpful. Spinal tap, where we have to access cerebral spinal fluid, which is the fluid that surrounds the brain, is really indicated if we have a serious concern for a infection in the brain called encephalitis or meningitis. Now, if the child is very young or unvaccinated, and of course, if the child is not acting right, then these are considerations in an emergency department setting often. But this is not part of evaluating a first unprovoked seizure. We really do these studies if we think there's an immediate provocatory cause we need to look at. So besides doing a good history, a good examination, the other test that is indicated in a non-urgent matter is what's called an electroencephalogram, an EEG. So I already mentioned that your brain works like a computer with billions of cells that have normal electrical activity or conversation, if you will. What we can do with an EEG, which is just many wires, this is not a painful test, and we don't sedate the child or adult for this test because sedation affects the brain activity. The whole point of an EEG is we're trying to evaluate abnormal electrical activity on the scalp surface. We are doing our best with limited technology to see if there's microscopic abnormal electrical activity, even when that child or adult is not having a seizure, which might tell us, this part of the brain or the entire brain is showing microscopic temporary abnormalities that tell us this brain might have another seizure. That's what an electroencephalogram is for. It helps us determine the risk of seizure recurrence after a first unprovoked seizure. Sometimes we do an EEG and we know as epilepsy experts and neurologists, this type of EEG at this age with the history provided by the eyewitness account fits into this exact epilepsy syndrome. I know what this is. So the EEG can be very helpful. Some of us like to wait a day or two at least after the seizure occurred to make sure that when we get an EEG, whatever dysfunction we're picking up, whatever abnormalities we're picking up really is reflective of that child's brain after the seizure that happened is gone and their brain has recovered. Now, there are times where we can't wait and we need to do an EEG much sooner. And also the length of the EEG is important. Not surprisingly, most of the time we do a 20-minute to a 40-minute EEG in an outpatient setting. But the longer your EEG, the more window you have into that child's brain activity and the more sensitivity and higher yield of potentially picking up these microscopic abnormalities that can come and go. But there are limits to what kind of EEG we can do. It really depends on our degree of concern, our degree of suspicion, how well or unwell that child looks. But this is usually done as an outpatient basis and helps inform our decision. Now, I want to stress, like any other test in medicine, this is not a perfect test. Just because the 20-minute, 1-hour EEG comes back normal does not mean the child did not have a seizure. And it does not mean that child might not go on to develop a second unprovoked seizure and therefore meet the clinical definition of epilepsy. And vice versa, sometimes an EEG can have some subtle abnormalities. And while that absolutely increases the risk that epilepsy will evolve, it's not always guaranteed. And there are some children and adults who have significant behavioral or intellectual disabilities where we simply can't get a non-sedated EEG. They will not lay still. And in those circumstances, we make more decisions based on our history examination and other modalities of diagnostic testing. Now, when we do an EEG, we're looking for a couple of things that predict risk of epilepsy, risk of more unprovoked seizures. We're looking for slowing in one region of the brain specifically, not everywhere. If you have significant intellectual disability, severe autism, history of old significant brain injury, then your entire brain can be a little slow, reflecting your neurodevelopmental disabilities. But when we see one area of the brain that's slower than other parts of the brain, that tells us, there might be something wrong in that region of the brain that could predispose to seizures. The other thing we're looking for besides focal slowing is what's called epileptiform activity, which is essentially microscopic, excessive electrical activity from a group of brain cells. And epileptiform activity looks sharp. So I'll show you some examples. That its sharpness and its physical wave characteristics tells us there's excessive electrical activity coming from that region of the brain where we have the electrodes. So this is an example of a normal electroencephalogram. So we have usually about 10 pairs of electrodes that we try to cover the child's scalp surface area. And we're comparing the left side of the brain to the right side of the brain, the front to the back to the sides. And we know that there's normal changes that occur with drowsiness and sleep where the brain activity can slow down. There's normal activity when a child moves. Usually we can differentiate fidget and sinus and from actual activity coming from the brain. And of course, in this day and age, most of the time when we do an electroencephalogram, we are also capturing video, which makes it easier for the person interpreting the test to know, was that something artificial coming from the child rubbing their eyes, or maybe an infant nursing versus actually coming from the brain. But these are a couple of examples of abnormal electrical activity on an EEG that we worry about. So here, I know you might not be experienced in reading EEGs, but what anyone can see is, there's activity that looks very sharp that is happening intermittently. So this is example of epileptiform discharges, abnormal excessive electrical activity that's occurring. And over here, we have these first 4 lines are the left side of the brain. The next 4 lines are the right side of the brain. And I think most of us can see that the right side of the brain, the second 4 lines, looks slower. And then there's some sharp activity here and there. So these are examples of epileptiform activity and focal slowing that tells us these brains are high risk for seizures and therefore epilepsy development. After a first unprovoked seizure, I want to stress that just because a child or adult, let's say sometimes we do an EEG for other reasons, maybe we're concerned about some changes in mood or behavior. Unless that child or adult has manifested with at least one seizure or seizure-like episode, we really want to be careful not to overtreat the EEG itself. Some people can have an abnormal EEG and never have any seizures. And again, some people can have a normal EEG and have full-blown epilepsy. So at the end of the day, our decisions are based clinically based on what we're seeing and what we're not seeing. And we're using these tools of EEG and neuroimaging to decide what are the risks of more seizures, and also what could the cause of the child's epilepsy be. So in terms of imaging, a lot of kids who end up in the emergency department with these scary first-time seizures end up getting a CAT scan. Now, CAT scans are excellent tools because they're very fast. They take only 3 to 5 minutes to obtain. They can give us slices through the brain. They can really identify if there's something obvious, like a big bleeding area or trauma, or even a mass, something that doesn't belong in the brain. But really, a lot of CAT scans, they're not that helpful, and they don't have the detailed resolution to tell us that there's a subtle abnormality in a region of the brain, like a malformation the child could have been born with, or even remote brain injury that is now manifesting as a seizure. So really, CAT scans should be done in children who present with a seizure when we actually are worried that this was provoked. We're worried that the child's not waking up normally, that they're not as strong as before the seizure. They're not acting right. So we're really worried about an underlying serious brain injury or process that we like to know about. What is a lot better than a CAT scan and does not have any radiation like a CAT scan is a brain MRI, magnetic resonance imaging. Now that technique takes a lot longer. It takes a good 30 minutes to an hour. And if the child is either just young or has developmental or behavioral difficulties and cannot lay completely still for the duration of that image, we have to sedate that child, which of course could have its own potential, but usually minimal risks. So usually a brain MRI can be obtained non-urgently. If the child's recovered after the first seizure, we like to get this study as an outpatient. And again, it's the best way for us to look for subtle structural causes of epilepsy, which you will recall is one of the major causes of epilepsy. So anything in the brain that we know as radiologists or doctors or neurologists that can cause excessive electrical activity, again, scar tissue, a brain malformation syndrome, low-grade tumor, or extremely rarely cancers in children. These are called structural causes of epilepsy. And once we see that, it has a lot of positive predictive value in saying this child who had a first unprovoked seizure is going to develop epilepsy. So we have studies, modern day studies, that tell us again that the electroencephalogram and the brain MRI independently have positive and negative predictive value, meaning if they have abnormalities that are relevant to epilepsy development, they're going to predict higher risk of epilepsy development in that child. Or if they're both normal, then there's a lower probability that child will go on to have more seizures. So again, the most important things I mentioned are getting a good history, making sure that the spell was in fact epilepsy and not breath holding or a panic attack or something that happens after fainting if you're not getting enough oxygen or blood flow to your brain. Also making sure that we're not missing a dangerous cause of a provoked seizure. We're going to order an electroencephalogram and a brain MRI in most individuals. Now, what about doing genetic testing? So there are now studies that show when we don't have an obvious cause of the child's epilepsy, or even beyond that, sometimes we see a child and the story of their seizures, usually they've had more than one seizure, is very consistent with a specific epilepsy syndrome. Then we can focus in with razor focus on the potential gene change that could be causing the epilepsy. This is not, I would say, standard of care as of yet, but more and more epileptologists and pediatric neurologists are feeling comfortable doing genetic testing, and with the help of a lab or geneticist, interpreting that test and putting into a context for the family. Now, there are some individuals, again, individuals with significant chronic disabilities, such as significant intellectual disability, significant autism, cerebral palsy, where we know once that child's brain has demonstrated an unprovoked seizure, even before we get the MRI, electroencephalogram, or even genetic testing, if it's indicated, that there's a more than 70, 80% chance seizures will recur. And we will still do the appropriate diagnostic tests, but we're not going to wait for those tests to diagnose epilepsy and talk about the risks and benefits of medication interventions. So to treat or not to treat, there's a number of questions we consider that I'm going to go through quickly. Now, there is a fear as a parent or as a child or adolescent or adult who's had a seizure that if this person has one more seizure, it's going to be life-threatening and it's going to cause weakness or intellectual problems. The good news is that rarely happens with new onset epilepsy. Even long seizures, as long as they're not caused by some sort of underlying ongoing brain process such as infection or inflammation, even prolonged seizures, as long as we maintain the child's airway and oxygenation and blood flow to the seizures, do rarely cause actual brain injury. I'm not trying to make light of the dangers of seizures, but the truth is most individuals with epilepsy who get injured, they get injured from falls, drowning, burns, suffering burns, things of that nature. Sudden unexpected death in epilepsy patients, which unfortunately is a very real entity, mainly causes premature death in individuals who've had drug-resistant epilepsy, usually for years, especially convulsive seizures at nighttime and don't have a bed partner who's watching over them. It's extremely rare with new onset epilepsy for serious brain injury to occur from the seizures themselves. Now, when that child has had a first unprovoked seizure, there are studies that show that if they're going to go on to develop epilepsy and they're going to have therefore a second seizure or other seizures, most of the time within a year, if not 2 years, that second seizure will occur. So most of the time within a year or two, the epilepsy will declare itself, even if the EEG is normal, even if the brain MRI is normal. In children who are typically developing, who have typical intelligence, who don't have chronic neurodevelopmental disabilities, when we've done studies, only about 10% of them will actually develop 10 or more seizures when they're followed for like a decade. So in children who are typically developing, who don't have chronic disabilities, difficult to control epilepsy is the exception, not the rule. But when we take into consideration all children, especially children who have chronic disabilities or a structural cause of epilepsy, old brain injury, an area of scar tissue from something that might have happened in utero or after birth, brain malformation syndromes, or even low-grade benign tumors, then we're a little more worried about their epilepsy, that it might be more difficult to treat and we need to follow them even longer. So I'm going to skip this slide. Now, it's also really important to note, what if that first seizure was really long, or if the seizures clustered, multiple seizures in a day? Well, the good news is just those two things alone do not predict by themselves that the child for sure will develop epilepsy. However, if the child's going to experience more seizures in the future, then unfortunately there's a higher probability that they will be prolonged again or clustering. And that's when we start to worry. So when seizures start to become recurrent, provoked, or lasting continuously more than 5 minutes, we really want to intervene, and we want parents and loved ones and care providers to intervene, because that's when we start to worry about brain injury from various causes, including breathing problems and choking. And we have now 3 commercially approved forms of abortive emergency care. We've had a rectal suppository called Diastat for for at least 2 decades now that has been very effective when given for a sustained seizure or seizure clustering to stop that seizure and continue to protect that child or adolescent against more seizures. But of course, it could be awkward or physically difficult to administer a rectal medication to a larger individual, especially when they're stiff or convulsing from a seizure. So now we have 2 forms of intranasal sprays that can help sedate the brain and stop seizure clustering. And we can also use them for sustained seizures off-label. And it's also equally important as a parent that you advocate for your child to have a seizure action plan for daycare, for school, for camp, where the physician communicates with your help and your permission the type of seizure that the child's having, what defines a seizure emergency, and which of these emergency medications should be applied in case of an emergency. This could be very helpful. And these medications, I want to stress, are designed to be given by non-medical people because they don't require any sort of medical monitoring after they're given, and they could be very helpful. So here's what I want to stress. A lot of parents will ask me, well, you're telling me my child had a seizure and yet you're not prescribing any medications. Why not prescribe another medication? Why are we waiting for the EEG, brain MRI, or other testing? Or if those tests are negative, why are we waiting for another seizure to happen? Now, the explanation is this. When we historically in the past have been more aggressive and have started daily anti-seizure medications after a first unprovoked seizure, as opposed to waiting for a second unprovoked seizure, earlier intervention with medications does not prevent the development of epilepsy. That is such a critical point. Yes, anti-seizure medications are about 60–70% effective in reducing the frequency or duration or severity of future seizures, but they are not a cure that prevents the development of epilepsy. We wish and we pray that one day we have a cure or true preventative measure for epilepsy. So that is why, and beyond that, anti-seizure medications don't even change the long-term outcome of that child or adolescent's epilepsy. Think of it as a very fancy chemical Band-Aid for that child's underlying cause of their excessive electrical of their brain, their seizures. So with the medication early, or you wait after a second unprovoked seizure, if that child's going to have easy to control epilepsy, or the type of childhood epilepsy that he or she might grow out of before puberty, or unfortunately, if they're going to have a drug-resistant form of epilepsy, starting the seizure medications early or not will not change that long-term prognosis or outcome. And beyond that, it's important to note that our anti-seizure medications are not perfect. They could have sometimes predictable, but sometimes very dangerous and unpredictable side effects. Some side effects are dependent on the dose. Sometimes they can affect mood and behavior and learning. Many of them require blood monitoring to make sure your insides, the child's organs are okay. The way we choose anti-seizure medication is, number one, once we've determined the child has epilepsy based on 2 or more unprovoked seizures, once a child has demonstrated 2 or more unprovoked seizures, we already know that there's a more than 60% chance they're going to have more seizures. But also based on the seizure type, with our EEG and MRI informing that, the child's age, whether it's a female or a male, whether they might be sexually active or not, because some of our medications can be very dangerous if the female patient were to get pregnant for the fetus. If a child's overweight, we might choose a medication that might suppress their appetite. If they're underweight, we might want to stay away from those medications. Depending on their swallowing ability or their developmental stage, we might need a liquid versus a chewable tablet versus sprinkles versus a tablet they can swallow. And of course, if a child already has some certain behavioral problems, we might choose an anti-seizure medication that is better for mood. So there are all sorts of things we take into consideration, potential side effects that actually might be desirable from a medication for that child. But at the end of the day, we're basing it on evidence. Certain medications are indicated for focal onset seizures. Certain medications are only indicated for primary generalized epilepsy, and certain medications can treat both. So all of these factors really matter. But at the end of the day, how that child tolerates the medicine, how it makes them feel is really important. Equally important to preventing preventing more seizure clustering and dangerous seizures and trying to control the seizures. So that's how we approach the treatment of epilepsy. I'm going to skip this. But it's also, as a parent, I know we're not only worried about future seizures after a first unprovoked seizure or after the definitive diagnosis of epilepsy, but we're also concerned about how the epilepsy or its underlying cause and treatment can affect the child's mood, behavior, and learning. So epilepsy is truly a neuropsychological disorder where it's hard to tease out those factors. And we have plenty of data that show us that children, even after a first unprovoked seizure, are at higher risk for having pre-existing, probably undiagnosed, sometimes subtle and sometimes not so subtle, possible learning difficulties. So we want to be equally proactive in identifying those with the help of the school and or other experts and intervening. Also, as a parent, if we have a young child or infant who's diagnosed with epilepsy, besides the future risk of the seizures, we want to know if our son or daughter will be able to keep up with his or her peers in terms of their motor skills, socialization, and other abilities. So that's called adaptive behaviors. And there are studies that have shown if we can control the child's epilepsy, if it's the type of epilepsy that can be controlled with medications, and if they don't have pre-existing significant developmental disabilities to begin with, then usually they're going to do well. But if they continue to have drug-resistant seizures, where 2 or more appropriately chosen medications are not stopping all the seizures, or if they have a particularly bad form of epilepsy called an epileptic encephalopathy, then we need to be more careful for that child and provide, in addition to anti-seizure care, other services to help maintain and maximize that child's developmental potential. So presenting at home, at school, in the community, or in the doctor's office with certain behavioral problems, in particular, low self-esteem, signs of anxiety, depression, feeling withdrawn, we really want to think about, yes, could it be a side effect from the medications? Are there underlying developmental disabilities or learning problems I haven't found? But you also want to know how the parent, the siblings, the teachers, the relatives, and the community is responding to that person's epilepsy. Epilepsy, again, is one of the most common manifestations of neurologic problems in childhood. So we want to be accepting of epilepsy. It is unfortunately a part of the human brain. And we really want to make sure that we provide appropriate mental health screening and services to continue to help that individual move forward with their voyage of epilepsy. So there are, these are the key messages I want to drive home, that epilepsy is very common. It is, in fact, treatable in the majority of individuals. Now, there are many other treatment options besides anti-seizure medications, but for new-onset epilepsy, anti-seizure medications are the standard of care, and they're usually the easiest. The only other things that have been evaluated in a very select and small group of children is the ketogenic diet, but it definitely entails more work, although some people might argue it's more natural than taking a medication. But in general, in the great majority of individuals, anti-seizure medication is the first option for treatment. There are many causes and forms of epilepsy, so it's really important that the physicians try to figure out the cause of a child's epilepsy, and that you as an advocate understand this as well and appreciate it so you can better educate yourself and your loved one. There are many forms of childhood onset epilepsy that start before puberty, usually in an intellectually typical developing child with no motor disabilities and a normal brain MRI, where by definition we know this epilepsy should go away before puberty. If epilepsy starts or persists beyond puberty, or especially if there's an abnormal brain MRI with a structural cause of seizures, that individual is much less likely to just outgrow their epilepsy. Now, we could still often treat their epilepsy with medications, ketogenic diet, certain devices, or sometimes even brain surgery, but we need to continue to follow that individual for their epilepsy. So epilepsy and its treatment is really a voyage, and the child, adolescent, and their loved ones really help guide us, the physicians, in our decision-making approach to epilepsy. And a lot of times we have to be prepared to change our approach and to listen to what's being said and any concerns. Thank you so much for your time and for listening in. I'm sorry I went right. I think I spoke for most of the time. I'm not sure if there are any questions or anything else that I can answer at this point. Yeah, so there are some comments about me sharing my PowerPoint. Yes, that's something I can share with the individuals who organized our Interactive Epilepsy Awareness Day. I'll be happy to share that in a PDF format, which will probably be easier. Okay, thank you everyone for your time.
Thank you so much, Doctor. Hello, can you hear me?
Thank you for having me again. Okay. Take care.
I can't really hear them. Maybe your volume is low.
Thank you again. Take care.